Please subscribe to my channel and do hit the bell icon. Okay, so today we are going to discuss about drugs affecting renin-angiotensin system. First of all, what is this renin? Renin is an enzyme that resides in the juxtaglomerular cell of kidney. So very briefly we'll check out what exactly is this juxtaglomerular apparatus. Suppose this is your Bowman's capsule and this is the blood vessel, obviously the afferent and the efferent arterioles. These both muscles of the afferent arterioles have got a baroreceptor. And just nearby to this afferent arteriole will be a part of the distal convoluted tubule. So the macula densa, the specialized cells present on the distal convoluted tubule, the macula densa of the distal convoluted tubule and the baroreceptor of the afferent arteriole, these together forms the juxtaglomerular apparatus, and over here resides your enzyme renin. Next, angiotensin. Angiotensin is a polypeptide which step by step will be converted into a very potent vasoconstrictor. So now we will check out the renin-angiotensin-aldosterone system. First of all, we will check out the normal physiology and then we will see what kind of problems or what kind of disorders can be solved when we inhibit this system. Okay, so first of all, we'll know about the renin-angiotensin-aldosterone system. Suppose this is your blood vessel, this is your liver, kidney, lungs, and this is your brain along with its spinal cord. Stimuli that initiates the renin-angiotensin-aldosterone pathway mainly includes dehydration, sodium deficiency or hemorrhage. As such, blood volume is decreased, that decreases the blood pressure, and as blood pressure falls, the blood supply to various organs also decreases. Similarly, the blood supply to the kidney is also being reduced. Now, we know that kidneys are made up of millions and millions of small units known as nephron. So, we will check out one nephron. Suppose this is your Bowman's capsule, the proximal convoluted tubule, loop of Henle and the distal convoluted tubule. The afferent arteriole which is supplying the blood to the nephron and the efferent arteriole from which the blood is leaving from the nephron. Now, what is the situation? The situation is due to dehydration and sodium deficiency or due to hemorrhage, there was a reduced blood volume and therefore reduced blood pressure has been seen. Since blood pressure is reduced, the blood supply to various organs has also been reduced, and one of that organ what we are talking about is kidneys. Okay, even kidneys is receiving a reduced blood supply, and the afferent arterioles are also receiving a reduced blood supply. So in the afferent arteriole also there will be a reduced blood supply. Now, the speciality of these afferent arterioles are the vascular smooth muscle of the afferent arterioles contains a specialized cell which are baroreceptors. These baroreceptor cells can sense the blood pressure, and whenever the blood pressure or you say the blood volume is reduced, then the baroreceptor senses this and it will get activated. So this is one thing. Now you know about this glomerular filtration. The fluid is filtered and then it moves to the Bowman's capsule, and one of the component of this glomerular filtrate is the sodium. Okay, so sodium also gets filtered and moves to the Bowman's capsules and then approaches to the proximal convoluted tubule. Now these glomerular tubules are made up of, this proximal convoluted tubule is made up of cuboidal epithelial cells, whereas the loop of Henle and the distal convoluted tubule are made up of the columnar epithelial cells. Now suppose whatever amount of sodium got filtered and it reaches to the proximal convoluted tubule, nearly 65% of the sodium is reabsorbed from the proximal convoluted tubule, and the remaining amount of sodium will move into the other part, that is loop of Henle. When it reaches to the loop of Henle, nearly 25% of the sodium is reabsorbed back into the systemic circulation, and just 10% of the sodium which was getting filtered will now approach to the distal convoluted tubule. But this is a normal condition. Okay, this is normally what is happening. And what is the situation now? The situation now is either dehydration or sodium deficiency or hemorrhage. Under these conditions, what will happen? The blood volume was reduced. Okay, when volume is less, then the sodium concentration in the glomerular filtrate is also less. Upon that, when pressure is also less, then the fluid will be moving through the proximal convoluted tubule, loop of Henle and distal convoluted tubule very slowly, thereby sodium getting more time to get reabsorbed. So in a nutshell, what you can say, under these circumstances, less than 10% of sodium will be approaching to the distal convoluted tubule. When this happens, then the amount of sodium will be very much less. Okay, so what will happen, there are specialized cells present on the distal convoluted tubule, and the name of these cells are the macula densa. These are specialized columnar epithelial cells. See, normally the distal convoluted tubule is made up of columnar epithelial cells, but this particular area, there is dense amount of columnar cells which are very much dense. That's why the name the macula densa. Okay, so this macula densa will sense that it is receiving a less amount of sodium, and because of which it will also get activated. So this macula densa, these green cells mainly act as a chemoreceptor. Okay, so the baroreceptor present in the afferent arteriole gets activated when it receives a reduced blood supply, and this macula densa, it acts as a chemoreceptor that gets activated when less sodium is present in the distal convoluted tubule. So both these baroreceptors and the chemoreceptors, or you can say the afferent arteriole and the macula densa, these together form the juxtaglomerular cells, upon activation of which will cause a release of an enzyme, that is renin. Okay, renin will start getting released into the blood circulation whenever this juxtaglomerular apparatus will get activated. Now, not only this is responsible for the release of renin into the blood circulation, one more thing can trigger this renin release. That is, suppose this is your heart, and above your heart there will be a system known as the carotid sinus. Since the blood volume and blood pressure is reduced, various organs will be receiving less blood supply. Similarly, the carotid sinus will also it will also get a reduced blood supply, to which it will respond by informing this thing to the central nervous system, and the central nervous system will respond to this by increasing the sympathetic outflow. So when sympathetic nervous system will get activated, means all the adrenergic receptors will get activated, all the adrenergic neurons will get activated, and one of the adrenergic neuron will be approaching to this juxtaglomerular cells, so where beta 1 receptor will be present. Okay, beta 1 receptor is not only present in the heart, it is also present in the juxtaglomerular cells of the kidney, and when the beta 1 receptor of the juxtaglomerular cells of the kidney gets activated, it will also respond by increasing the release of renin. Okay, so there are two ways by which renin has been released. Okay, now renin is present in the blood circulation. What happens next? Next, the role is played by your liver. Liver is normally every time releasing a protein, an amino acid known as the angiotensinogen, and this angiotensinogen does not have any action as such. It is normally synthesized from the liver. Liver is a site of synthesizing proteins, so it is synthesizing one of the alpha 2 plasma protein, that is angiotensinogen. Normally, when now also you are sitting and normally in from your liver this angiotensinogen amino acid is been released, but now the problem is renin is also present in the blood circulation, and this renin will act on this angiotensinogen and it will convert it into angiotensin 1. Okay. Now, angiotensin 1 is present in the general circulation, and when it is passing through the lungs, in the lungs, the pulmonary blood vessels of the lungs, here resides a special enzymes known as the angiotensin converting enzyme, and this angiotensin converting enzyme will convert angiotensin 1 into angiotensin 2, and now angiotensin 2 is present in the general circulation, producing various effects. One more action is produced by this angiotensin converting enzyme, that is, they will act on bradykinin and will cause metabolism of bradykinin. Bradykinin is a kind of vasodilator, and when this vasodilator is being inhibited, so what will happen? There won't be vasodilation. Plus, these enzymes are responsible for converting angiotensin 1 to angiotensin 2, which is a very potent vasoconstrictor. So, angiotensin converting enzyme have got two roles. From one hand, it will convert angiotensin 1 to angiotensin 2, and with other hand, it will cause metabolism of bradykinin. Okay. Now we will check out various actions produced by this angiotensin 2 component. Suppose this is your adrenal gland. Inner pink part is the adrenal medulla and the outermost part is the adrenal cortex, and this angiotensin 2 will act on its receptor which is present on the zona glomerulosa of the adrenal cortex, and when it interacts with its receptor present on the adrenal cortex, it will cause release of a substance known as the aldosterone, which acts on the distal part of the nephron. Okay. Now we'll zoom up this thing and we'll check out what all things will be happening when aldosterone interacts with the distal part or the distal convoluted tubule of the nephron. Suppose this is the columnar cells present on the distal convoluted tubule. This is the basolateral membrane and this is the luminar membrane. This is the nucleus of the cell containing the DNA, and this one is the aldosterone which is freshly released from your zona glomerulosa of the adrenal cortex. So what is aldosterone will do, this will interact with the DNA and it will cause synthesis of two important proteins. One protein is the sodium potassium ATPase pump. So many sodium potassium ATPase will be synthesized on the cell. This is the first protein. The second protein which has been synthesized is the potassium channel. Okay, so aldosterone interacts with the distal convoluted tubule and it will cause synthesis of two important proteins. First protein is the sodium potassium ATPase which is formed on the basolateral membrane, and the second protein is the potassium channel which is synthesized in the luminal membrane. Now what is the action of this sodium potassium ATPase pump? Its action is to release 3 sodium molecules outside the cell. Outside the cell means in the systemic circulation, and to produce influx of 2 potassium ion inside the cell. Okay, so by this action, this cell will become rich in potassium and very much poor in sodium. Okay, so this particular cell is potassium rich cell because number of sodium potassium ATPase is being formed in the basolateral membrane, and the action of this sodium potassium ATPase is to pump out sodium and to pump in potassium, causing its increased availability of potassium inside this cell. Okay, so this is the action of sodium potassium ATPase pump. The another cell which is synthesized, or another protein which is synthesized, is the potassium channel. And the role of this potassium channel is it will favor both exit as well as entry of the potassium ion. But since this cell is rich in potassium, so it will favor exit of potassium ion into the lumen. And when inside the lumen the potassium ion is more, it will cause excretion of the potassium ion via the urine. So in a nutshell, we can say the action of aldosterone secretion is it will increase the sodium reabsorption and it will increase the excretion of potassium ion. Now, one more important thing regarding this is when sodium reabsorption is more, it will not come alone. inside the systemic circulation, but it will also catch the hands of one more friend, which is water. So sodium will not undergo reabsorption alone, it will also favor the reabsorption of water. Okay, you should always remember, sodium is always going everywhere along with water. Wherever sodium goes, the water will follows. You can also, practically also you people have been experienced, whenever you consume any salty or spicy, mainly salty food, you will feel more thirsty, because wherever sodium goes, water follows. Same thing happens over here. When sodium reabsorption is more, so water reabsorption also increases. So the action of aldosterone is, it will increase excretion of potassium and it will increase sodium and water reabsorption, or you can say it will increase the sodium and water retention. When sodium water retention increases, it will increase the venous return. Okay, so this is the action of the aldosterone. Next we'll check out various other areas where you will find the receptor of angiotensin 2. So suppose this is your superior and inferior vena cava, this is your right atrium and this is your right ventricle. These are all the blood vessels which are approaching to the lungs. And what kind of blood vessel approaches to the lungs? Yes, this is the pulmonary artery that approaches to the lungs. And in the lungs, the deoxygenated blood is converted into oxygenated blood. And suppose this is your pulmonary vein, and this pulmonary vein carries oxygenated blood and it passes it to the left atrium first and then to the left ventricle. These are all the arteriolar system. This is the capillary, which becomes venules, and then veins ultimately approaching to the venous system. Now, the angiotensin receptors are present both in the arteries as well as in the veins. So first of all, we shall study about the arteries. So when angiotensin 2 binds with its receptor present on the arteries, it will cause constriction of the arteries. Okay, it will cause arteriolar constriction. Next, what will happen when arteries constrict? See, blood is normally present in the left ventricles during diastole, which is known as the end diastolic volume, which is normally 140 ml. And when systole occurs, systole means contraction, when the left ventricle contracts, the stroke volume means normally the amount of blood ejected out will be 70 ml. Okay, but since the arterial system is getting constricted, it will favor a resistance for the movement of the blood into the arteries. Okay, so this resistance offered is known as afterload. So because of constriction of the arteries, it increases the afterload. So when afterload is increased, so normally 70 ml has been ejected out whenever the ventricles constrict, but because of increased arteriolar constriction, instead of 70 ml, nearly 40 to 50 ml of the blood will be ejected out after the left ventricular constriction. So you can say the stroke volume is been reduced when the arteries got constricted, or you can say it increases the afterload. Similarly, when angiotensin 2 binds with its receptor present on the veins, here also it will cause constriction of the veins. Now what happens when veins contract? Due to venoconstriction, large amount of blood is forced to the right side of the heart. When or you can say the venous return has been increased, and when venous return is increased, then more amount of blood will be approaching to the lungs for getting purification. Similarly, more amount of blood is been moved to the left side of the heart. Okay, when left side of the heart is receiving more amount of blood, so you can say this is known as preload, or there will be increase in preload, or you can say there will be increase in the end diastolic volume. Okay, so this is the areas where you will find the angiotensin receptor, and these all are the role produced or played by your angiotensin 2. So angiotensin 2 receptor you will find first of all in the zona glomerulosa of the adrenal cortex, which causes release of aldosterone. Aldosterone release will cause sodium and water retention, and it will cause increased potassium excretion. Plus angiotensin receptor is also available on the arteries as well as in the veins. Angiotensin 2, when binds with its receptor on the arteries, it will cause arteriolar constriction, which will increase the afterload. And the angiotensin 2, when binds with its receptor present on the veins, it will cause venoconstriction, which will increase the preload. Okay, so now we will have a brief summary of the renin-angiotensin-aldosterone system. So we know this is your angiotensinogen, which is a plasma alpha-2 globulin, which is normally synthesized from the liver. And conditions such as sodium loss or fall in blood pressure, fall in blood volume, or renal ischemia. So these things are sensed by the macula densa when it is receiving a low sodium amount or low glomerular afferent pressure, which is sensed by the baroreceptor, and because of which there will be enhanced sympathetic activity. All these things will cause synthesis of the enzyme renin. So this renin act on the angiotensinogen and it will convert it into angiotensin 1. Angiotensin 1 is a decapeptide. Next, this angiotensin 1, when it is approaching or moving through the lungs, it will interact with the enzyme, angiotensin converting enzyme, which normally resides in the pulmonary capillaries of the lungs, which will convert it into angiotensin 2. Now what angiotensin 2 will do? Angiotensin 2 is a potent vasoconstriction, and because of vasoconstriction it causes a rise in BP, because of which it will inhibit the renin release. Plus it will also cause the secretion of aldosterone, and this and even angiotensin 2 together will cause increase in sodium and water retention, because of which there will be increased blood volume, which also favors inhibition of the renin enzyme. So it is a kind of a negative feedback mechanism. When everything becomes normal, so better to inhibit the enzyme renin. Now this circulating angiotensin 2 also has a very short half-life, that is about 1 minute, and the first degradation product produced by the action of an enzyme aminopeptidase is a heptapeptide termed as the angiotensin 3. Angiotensin 3 is 2 to 10 times less potent than angiotensin 2, except in stimulation of the aldosterone secretion, in which it is equipotent. Angiotensin 3 is again attacked by another enzyme, that is another aminopeptidase, and converted into angiotensin 4. Both these angiotensin 3 and 4 is acted upon by another enzyme, angiotensinase, and it is converted into an inactive fragment. So this is all the life cycle of your renin-angiotensin-aldosterone system. Now we know that because whenever angiotensin 2 bind with its receptor, it will cause constriction of the arteries, because of which it increases the afterload, and it also causes constriction of the veins, which will increase the preload. Okay, now both afterload and preload is been increased. So in total you can say it increases the end diastolic volume, means more amount of pressure is been required to pump the blood. Okay, because of preload, the amount of blood in the left ventricle is increased. Because of increased afterload, it is offering more resistance. So because of which large amount of blood is filled into the left ventricle, or you can say congestion of the left ventricle is occurring. Congestion means large amount of blood is being filled into the left ventricle, and suppose this left ventricle is experiencing some kind of infarction, so it is a more problematic case. So it may lead to a condition known as congestive heart failure. Congestive heart failure means the left ventricle is unable to pump sufficient amount of blood after getting contracted, and it is filled with large amount of fluid. In addition to this, there is some kind of infarction which may lead to congestive heart failure. So it is a problem over here, and this can be treated by inhibiting this renin-angiotensin system. Next, we know this thing, angiotensinogen is converted into angiotensin 1 by renin, and angiotensin 1 is converted into angiotensin 2 by angiotensin converting enzyme, and this angiotensin 2 is producing action such as it is increasing the vasoconstriction, which increases the peripheral vascular resistance and thereby leading to hypertension, means increased blood pressure. Plus angiotensin 2 is also causing release of aldosterone, and this aldosterone is favoring increased sodium and water retention, which also lead to increased blood pressure. Okay, so in total angiotensin 2 causes increased blood pressure. It may lead to hypertension. So we have got few drugs such as angiotensin converting enzyme inhibitors. So when we inhibit this enzyme, there won't be angiotensin 2, so there won't be any vasoconstriction, there won't be peripheral vascular resistance, and therefore this increased blood pressure can be inhibited. Plus aldosterone secretion inhibited, everything, sodium water retention also inhibited, so venous return also inhibited, preload also inhibited, and thereby it also favors in inhibiting this hypertension. Okay, so we can inhibit this enzyme, because of which hypertension can also be inhibited. Okay, so because of this renin-angiotensin system, it may cause congestive heart failure, plus it may also responsible for hypertension. So by inhibiting this renin-angiotensin system, we can cause treatment of congestive heart failure, as well as we can cause treatment of hypertension. Next, inhibition of renin-angiotensin system. This can be achieved by first class of drug are sympathetic blockers, beta blockers, adrenergic neuron blockers, or central sympatholytics that decreases the renin release. So this is the adrenergic neuron, and if we inhibit this neuron, which is responsible for the release of renin into the blood circulation, by this also we can inhibit this renin-angiotensin system. Another class of drug is direct renin inhibitors. The example of drug is aliskiren. So we know this angiotensinogen is converted into angiotensin 1 by the enzyme renin. So what this drug aliskiren will do? This aliskiren will inhibit this renin enzyme. When renin is inhibited, then there won't be conversion of angiotensinogen to angiotensin 1, and therefore no question of angiotensin 2 or its kind of action. Okay, so this is a second method by which we can inhibit this renin-angiotensin system. The third way by which we can inhibit this is by inhibiting the angiotensin converting enzyme. So we have got angiotensin converting enzyme inhibitors. So what these enzymes will do, it will convert angiotensin 1 to angiotensin 2, and when we inhibit this enzyme, there won't be angiotensin 2 available. Another class of drug are angiotensin receptor blockers, by blocking the receptors. So we know these receptors are present on the arteries, on the veins, as well as on the zona glomerulosa of the adrenal cortex. Okay, when we are blocking the receptor present on the zona glomerulosa of the adrenal cortex, there will be inhibition of aldosterone secretion. When we block the angiotensin receptor on the arteries, there won't be any arteriolar constriction. When we block the angiotensin receptor on the veins, there won't be any venoconstriction. Therefore, there will be reduced preload, reduced afterload. Therefore, it can be used for the treatment of congestive heart failure as well as for the treatment of hypertension. Next, another class of drug is aldosterone antagonist. So we are antagonizing this aldosterone. Therefore, there won't be sodium water retention, and there won't be any loss of potassium. There won't be any increased venous return. There won't be any increased preload. Okay. Now, for this video, this first class sympathetic blockers, I have made a separate video for sympathetic blockers, and regarding this aldosterone antagonist, this topic is been taught in detail in the topic of diuretics. So I am not teaching these two class of drugs. So I will be concentrating basically on this direct renin inhibitors, angiotensin converting enzyme inhibitors, and the angiotensin receptor blockers. So we'll check out about these classes of drug one by one. First, coming to the direct renin inhibitors, that is aliskiren. Now suppose this is your enzyme renin. Whenever angiotensinogen approaches to the renin, it will act on it and it will convert it into angiotensin 1. This is the normal function of your enzyme renin. Now what is aliskiren will do? Aliskiren will block this receptor, enzyme renin. When this enzyme has been inhibited, then angiotensinogen is not able to approach to the renin, and there won't be any synthesis of angiotensin 1. That's it. Very simple mechanism of action of this drug allosterone. Allosterone just block the receptor, and because the receptor is blocked, this receptor is behind the bar, this enzyme is behind the bar, so angiotensinogen is unable to get converted into angiotensin 1. Very simple. Next, another class of drug is angiotensin converting enzyme inhibitors. Very simple. Like previous one, here the enzyme, the angiotensin converting enzyme is getting inhibited. Now the examples of drugs coming under this class are captopril, enalapril, lisinopril, perindopril, ramipril, trandopril, quinapril, imidapril, benazepril and fosinopril. Okay, so the drugs which is ending with pril are the angiotensin converting enzyme inhibitors. Among these drugs, just captopril is an active drug, whereas other drugs are prodrugs. These drugs needs to move to the liver, where these prodrugs are being converted into active drug. Next, almost all the drugs are being excreted via renal elimination except fosinopril, which has got dual elimination, means it is eliminated via liver as well as via the kidneys. Okay, so that's all about these drugs. Next, regarding the uses, these class of drugs can be used in the treatment of congestive heart failure, as these agents inhibit the synthesis of angiotensin 2. So there won't be any angiotensin 2 mediated arteriolar constriction or venoconstriction, and there won't be any synthesis and release of the aldosterone. Therefore, it is widely used in the treatment of congestive heart failure. Next, it is also used in the treatment of hypertension, because there won't be any preload and afterload, and there will be reduced sodium and water retention. Therefore, it is also used in the treatment of hypertension. Next, this class of drugs are also used in the treatment of myocardial infarction. So, recent cases of myocardial infarction, you can say, to reduce the workload on the heart by reducing the preload and afterload, plus by inhibition of the aldosterone release, which will reduce the sodium and water retention and thereby venous return. Angiotensin converting enzyme inhibitors are often given in patients with recent acute myocardial infarction. Next, lastly, it is also used in cases of diabetic nephropathy. So we should know about this. We'll have few words about this diabetic nephropathy. Suppose this is your nephron and this is the blood vessel. This is the afferent arteriole and this one is the efferent arteriole. These are the mesangial cells. So what exactly happens in diabetic nephropathy is hardening of this blood vessel will take place. Okay, both afferent as well as efferent arteriolar blood vessel hardening will be occurring. Next, angiotensin receptors are found in abundance in the efferent arteriole as that of the afferent. Okay, efferent arteriole have got large number of the angiotensin receptor, and this angiotensin 2 will bind to its receptor. Now, when the blood is passing, first it will approach to the afferent arteriole and then it will approaching to the glomerular capillary system and then to the efferent arteriole. And along with blood, one of the component, that is protein, is also moving, okay, from the afferent arteriole to the capillary bed and then to the efferent arteriole. But what the problem is, the efferent arteriole have got large number of the angiotensin receptor, because of which it will cause constriction of the efferent arteriole. And when this efferent arteriole is been constricted, then what will happen? The proteins will be remaining in the glomerular capillary bed only, and it causes forcing of this protein to ooze outwards. Okay, so few protein will be oozing towards the mesangial cells and few protein molecules will be forced to ooze in the basement membrane of your endothelial cells. Okay, and the result is, and this result of this protein approaching to the mesangial cell is, it will cause overgrowth of these mesangial cells, and the result of this protein approaching to the basement membrane is, it will cause damage of the glomerular endothelial basement membrane, thereby it will cause damage of the entire glomerular apparatus. So this is what happens in the diabetic nephropathy. So when we give angiotensin converting enzyme inhibitors, so what will happen? It will just inhibit this thing. it will inhibit the constriction. It will inhibit the constriction of the efferent arteriole. That's it. And thereby favor the normal flow of the protein. So this is how angiotensin converting enzyme inhibitors can be used in cases of diabetic nephropathy. Next, we shall check out the adverse effect of these angiotensin converting enzyme inhibitors. And the adverse effect you can remember from the word captopril, the first drug, captopril. So, C is for cough. Angiotensin converting enzyme not only converts angiotensin 1 to angiotensin 2, but it also causes metabolism of bradykinin. But when we inhibit this enzyme, means the bradykinin metabolism is also been inhibited. See, suppose this is your blood vessel or general circulation, and this is your lungs, and this is your angiotensin converting enzyme. So this angiotensin converting enzyme not only convert angiotensin 1 into angiotensin 2, but it will also cause bradykinin metabolism. Now when we are inhibiting this enzyme, so what will happen? It will inhibit the synthesis of angiotensin 2, but it will also cause inhibition of metabolism. Means now bradykinin is available in high amount, and this bradykinin, it will act on the respiratory system, leading to dry cough. So dry cough is one of the adverse effect of this angiotensin converting enzyme. Next is A is for angioedema. This is a rare but more complicated problem arised due to bradykinin only. Angioedema means there will be swelling of the nasal mucosa, throat mucosa, pharyngeal and laryngeal mucosa that may be life-threatening. P is for proteinuria. Protein occurs in urine. T is for taste changes. There may be taste changes or changes in the taste perception for any patient who is consuming AC. Next problem is hypotension. See, normally what happens when we are inhibiting angiotensin converting enzyme, so angiotensin 2 level will be reduced. But normally renin will be released, and angiotensin 2 will favor inhibition of renin release. But when angiotensin 2 is not available, so renin will be continuously released, and there will be increased plasma renin activity. And because of this increased plasma renin activity, it may lead to hypotension. Okay, so to inhibit this thing, it is advised that we should start with low doses of angiotensin converting enzyme inhibitors, low doses, so that very reduced amount of angiotensin 2 is been inhibited, and slowly gradually we can increase the dose of the drug. Next, P is for pregnancy. We need to avoid this drug during pregnancy because it is highly fetotoxic. R is for rashes, which may occur because of angioedema only. I is for increase. There will be increase in renin and increased in potassium level. L is for low, and there will be low angiotensin 2 and low aldosterone. Now these two things are interconnected. When angiotensin 2 level is less, so obviously there will be increased renin, because angiotensin 2 is only responsible for inhibiting renin release. When angiotensin 2 level is less, so it may cause increased renin. Similarly, aldosterone. What is normal action of aldosterone? Aldosterone causes increased excretion of potassium. But when we are inhibiting this enzyme, angiotensin converting enzyme, there won't be angiotensin 2. If angiotensin 2 is not there, it will not cause release of aldosterone. When aldosterone is not available, so in our body excess amount of potassium will be there. So these all are the adverse effects of angiotensin converting enzyme inhibitors. Next, we'll check out the last class of the drug, that is angiotensin receptor blockers, that is the ARBs. Now we know these are the drugs that will inhibit the receptors, or they will cause blockage of the receptors. So the receptors are mainly available in the arteries, in the veins, plus in the zona glomerulosa of the adrenal cortex. So what these drugs will do? These drugs will bind with the receptor and it will cause blockage. So angiotensin 2 is available, but they cannot approach to the receptor, because in these receptors ARBs are already sitting over there. So this is the mechanism of action of the angiotensin receptor blockers. They will just sit on the receptor and they will block the receptor, so that angiotensin 2 will fail to approach, to interact with these receptors. Next, drugs. Examples of drugs of angiotensin receptor blockers are losartan, candesartan, irbesartan, valsartan, olmesartan, telmisartan, and iprosartan. So everything ending with sartan comes under angiotensin receptor blockers. Next, uses are quite same, that is, it is used in the treatment of congestive heart failure, hypertension, myocardial infarction, and also in the diabetic nephropathy. So we can say angiotensin receptor blockers can be used as an alternative to angiotensin converting enzyme inhibitors when there is a condition where angiotensin converting enzyme inhibitors are been contraindicated. In that case, we can give angiotensin receptor blockers. Next, regarding the adverse effect of these ARBs are also same except the first two. Since these adverse effect is produced because of bradykinin. See, here ARBs will not inhibit the enzyme angiotensin converting enzyme. This enzyme will be converting angiotensin 1 into angiotensin 2 in one hand, and in second hand it will also cause metabolism of bradykinin. Okay, so everything is happening in its normal way, just these enzymes are blocking the receptors. So in our body angiotensin 2 is available, means the activity of angiotensin converting enzyme will be present, but it is an add-on advantage of ARBs over angiotensin converting enzyme inhibitors, because angiotensin receptor blockers are not inhibiting the metabolism of bradykinin. Here bradykinin metabolism will be taking place, and the first two adverse effect, that is cough and angioedema, is occurring because of bradykinin. Since the bradykinin metabolism is been taking place, so the first two adverse effect is not being seen in the angiotensin receptor blockers. So this is all about the angiotensin receptor blockers, and with this I end up my lecture regarding the drugs affecting renin-angiotensin system. I hope you people found this video helpful. Thank you for watching.